Has a doctor ever told you that you're a little anemic or that your iron is low and handed you an iron pill and that was the end of the conversation? If that has happened to you, I need you to stay with me for this entire video. Not part of it, all of it. Because that iron pill fixed a number on a page. It did not answer the question of where your iron is going. And for people our age, that unanswered question is one of the most dangerous things in medicine. Let me show you why. When doctors actually investigate iron deficiency anemia in men and in women past menopause, here is what they find. About 1 in 3 has something wrong in the digestive tract causing it. And when they look inside the colon, they find a cancer in about 9% of them. 9%. That is more than 10 times the rate you'd find by screening the general population. 9% is a higher number than any warning sign I am going to show you today. Higher than blood in the toilet. Higher than anything you could ever see by looking. And it comes with no bathroom sign at all. None. It just feels like being tired. Now, I want to be fair to your doctor because I'm not here to make you distrust them. Sometimes low iron really is just diet. But the professional guidelines are not vague about this. They say iron replacement has to be paired with actually finding the cause. And the Gastroenterology Association that wrote those guidelines admits, in writing, that there is significant variation in whether doctors do that part. So this comes down to whether the question got asked in your case. And if nobody asked it, you are the one who has to. That's what today is. Stay with me. Let me make this real. Gwen is 72, from Eugene, Oregon. She came to me about a sore shoulder. On her way out the door, almost apologizing, she said, "While I'm here, I've been checking the toilet every morning for 8 months, watching the shape. I read that if it goes thin like a pencil, that's colon cancer. It hasn't, so I figure I'm fine." I asked her one question. "Gwen, how's your energy been?" She went quiet, exhausted, for nearly a year. The kind sleep doesn't touch. Her daughter had twice said she looked pale, winded carrying groceries, and she'd handed every bit of it to being 72, because that's what 72 is supposed to feel like, isn't it? Gwen was watching the wrong thing. 8 months of genuine diligence, aimed at a sign the medical evidence does not support, while the sign that actually predicts this was sitting in how she felt every afternoon at 3 o'clock. We ran a blood count. She was anemic, bleeding somewhere, slowly, in amounts far too small to ever see. Her story ends well, and I'll come back to it. But first you need to know why she was watching the wrong thing. Because she didn't invent it. She was taught it. The most famous warning sign about your stool is a myth, and it is roughly 140 years old. One more, because this is the other half of the damage. Harold is 69, in Akron, Ohio. He wrote, "Dr. Clark, my stool has been narrow for about 3 weeks, thin like a ribbon. I've read this means colon cancer. I'm terrified and I haven't told my wife." Harold, you are almost certainly not in the danger you think you're in. I'll show you the research shortly, and I think it will lift something off your chest. But look at what's happened here. Gwen watched the wrong sign and felt safe when she wasn't. Harold watched the same wrong sign and is terrified when he probably needn't be. One bad idea, hurting 2 people in opposite directions. That's what today is for. And Harold, tell your wife. 3 weeks of carrying that alone is its own harm. If you've been quietly worried about something in the bathroom and never said it out loud, comment here. That's all, no explanation. I want you to see how many people are standing exactly where you are. I'm Dr. Clark. What I care about is the gap between what a 15-minute checkup catches and what's happening the other 364 days a year. This topic lives in that gap for a reason that isn't medical. Nobody talks about it. It's embarrassing. So people learn it from the internet, where the loudest voice wins, and the loudest voice here is wrong. Today, the myth. Then the 5 signs that actually carry weight, ranked by evidence. Real numbers, real sources, on screen. Some of it will reassure you, some won't. All of it is true. Before I can show you why the famous sign is wrong, I have to give you one piece of anatomy. Just one. Everything else in this video is built on top of it. Here's the belief, and see if it sounds familiar. Your colon is a pipe. Stool travels down the pipe. If something grows in the pipe and narrows it, then what comes out of the pipe gets narrower, like squeezing toothpaste through a pinched tube. It's an intuitive picture. It's a satisfying picture. It's the reason the pencil stool idea feels so obviously true the first time you hear it. The problem is that your colon is not a pipe. Your colon is a muscular tube, roughly 5 feet long, And it is not a passive channel that things fall through. It squeezes. It has layers of muscle in its walls that contract in waves, actively kneading and pushing everything along. It's less like plumbing and more like a hand-working dough. And here's the part that changes the whole picture. What comes out is shaped mostly by how much water is in it and how those muscles squeezed it, not by the geometry of the tube it passed through. A soft, well-hydrated stool doesn't take the shape of the pipe. It takes the shape of the last contraction that touched it, which means it can come out narrow on a morning when nothing whatsoever is narrowing your colon, because you were a little dehydrated, because your gut was spasming, because that's simply how it got squeezed on the way out. There's a real tool built on exactly this. It's called the Bristol Stool Form Scale, developed in 1997 by two doctors in Bristol, England, named Lewis and Heaton. They took 66 volunteers, measured how long things actually took to travel through the gut, and compared that against what the stool looked like. The correlation was strong, so stool form genuinely does tell you something real. It tells you about transit time, how fast things are moving. It was never validated as a cancer detector, and it isn't one. So here's the one sentence I want you to carry through the rest of this video. Shape tells you about speed. It doesn't tell you about growths. Now hold that next to a completely different category of sign, blood. Blood in your stool isn't a shape. It's a substance that should not be there at all. Nothing about hydration produces blood. Nothing about a muscle spasm produces blood. When blood appears, something is bleeding, and there is a limited list of things that bleed. That's why it carries weight that shape never could. It's not a matter of degree, it's a different kind of information entirely. The same is true of color sometimes. Your stool is brown because of bile. Your liver makes bile, it's green at the source, and as it travels your gut, bacteria convert it. The end product is a pigment called stercobilin, and that is the brown you recognize. So if your stool goes pale, clay-colored, chalky, almost white, that's bile not arriving, which means something is interfering upstream, in the liver or the bile ducts or the pancreas. That's real information, and it earns a call. So, some signs report on speed. Some report on a substance that shouldn't be there. And some, shape especially, report on almost nothing at all. Everything from here is about telling those three apart, because the entire genre of videos on this subject has them ranked exactly backwards. Let's take the famous one head on. The claim, and you have heard it, is this: stool that's persistently thin, narrow, ribbon-like, pencil-like, that's a classic early sign of colorectal cancer. It's stated with total confidence. It's usually saved for last, as the big reveal. Here's what the evidence actually says. In 2009, a gastroenterologist named Farhad Borhan Manesh published a paper in a journal called Digestive Diseases and Sciences. The title is not subtle. It's called Low-Caliber Stool and Pencil-Thin Stool Are Not Signs of Colorectal Cancer. He went back through the literature to find where the idea came from, and he found it. In the late 1800s. This idea is older than antibiotics. It's older than the discovery of blood types. It was conceived in an era before we could see inside the colon at all, by people reasoning from exactly that intuitive pipe and toothpaste picture I just took apart. Now here's the part that I find genuinely remarkable. By the middle of the 20th century, the authors writing the major gastroenterology textbooks had looked for the data behind it, found there wasn't any, and practically dismissed the concept. They dropped it. It should have died right there. It didn't. It crept back into the standard textbooks of medicine anyway, including newer editions, not because evidence arrived, but because it sounds right. It survived on inertia. And Borhan Manesh's conclusion is blunt. In the absence of genuine cancer symptoms, referring someone for a colonoscopy based only on decreased stool caliber is unwarranted. It exposes patients to unnecessary risk and discomfort, and it strains healthcare resources that are already stretched thin. And this isn't one contrarian voice. A gastrointestinal oncologist at Houston Methodist, Dr. Kirtan Naudiyal, says the same thing. Thin or narrow stools alone are not a reliable indicator of colon cancer. But I want to show you the strongest evidence, and it's not any single paper. It's a silence. In 2011, researchers in the UK published a systematic review in the British Journal of General Practice. They pooled 23 separate studies to work out which symptoms actually predict colorectal cancer in ordinary practice. It's free to read. I'll put the link below. They found real numbers for rectal bleeding, Real numbers for anemia. Real numbers for abdominal pain, for weight loss, for changes in bowel habit. Stool caliber isn't in it, not as a weak predictor. It isn't there at all. It isn't symptom the evidence base even bothers to track. So Harold, back to you, and to everyone who came here scared. Persistent narrow stool, all by itself, with no bleeding, no unexplained weight loss, no anemia, is overwhelmingly benign. The common causes are irritable bowel syndrome, ordinary constipation, hemorrhoids, an anal fissure, a small tear that can scar and narrow the exit. Real things, treatable things, not what you've been lying awake about. Now, I want to be precise because precision is the whole point of this video. I am not telling you caliber means nothing. If your stool has changed and stayed changed and you're seeing blood, or you're exhausted, or you're losing weight you didn't try to lose, that's a different conversation, and you go get looked at. What I'm telling you is that caliber is not the headline. It was never the headline. It got promoted to the headline by a 140-year-old guess. And notice what actually happened here because I think it matters. The field found this idea, looked for evidence, didn't find any, and said so out loud, in print, in a journal, under a title that leaves no room for interpretation. That's not medicine failing. That's medicine working exactly as it should. So let's do this properly. Let me show you the signs that are actually on the list. I'm going to give you 5. They're ranked by what the evidence says, not by what's dramatic. Quick note on how to read these. Doctors use something called a positive predictive value. I'll just call it the number. It answers, out of everyone who walks in with this sign, what portion turn out to have cancer? These numbers are small, and that's good news. Even the strongest sign here means the large majority of people who have it do not have cancer. That's exactly why we investigate rather than panic. This is the one that actually earns the top of the list. That 2011 review I mentioned pooled 13 separate papers on rectal bleeding. In people aged 50 and over, the pooled number came out at 8.1%, with a range across studies from about 2% to 16%. Another review found that in people over 60, it ran from about 6.6% up to 21%. Sit with that for a second because it cuts both ways. Roughly 8 in 100 is many times higher than the caliber sign, which has no number at all. And at the same time, more than 9 out of 10 people with rectal bleeding do not have cancer. Hemorrhoids are enormously common after 60, so this is not a sentence, it's a reason to be seen. Now here's the practical detail almost nobody tells you, and it's genuinely useful. There was a study of 604 patients who went to a clinic specifically for rectal bleeding. 22 of them, 3.6%, turned out to have colorectal cancer. And when they worked out what separated those 22, one thing stood out. Blood mixed into the stool itself, as opposed to blood on the paper or streaked on the outside. Blood mixed in raised the odds roughly 3 to 4 times over. So when you go, and you should go, bring that detail, mixed in or on the surface. It's a small thing to notice. It changes the picture. Most people have never been told it matters. Age matters too, and it matters more than people expect. In that same study, compared to people under 50, 50 to 69, roughly 5 times the odds, and 70 and over, roughly 8 times the odds. If you're in this audience, your age is doing real work in that equation. Not as a scare, as a reason not to let someone wave it off. This is Gwen's sign. And it's the one that most deserves your attention because it comes with no bathroom sign at all. In that same pooled review, anemia had a number of 9.7%. Read that again. Anemia scored higher than visible bleeding. The single most predictive sign on this entire list is one you will never, ever see in the toilet bowl. Here's what's happening. A growth in the colon can bleed a tiny amount continuously, day after day. Not enough to change the color of anything, not enough to see. But drip by drip, over months, your body loses iron faster than you can replace it. Your red cell count falls, and your blood gets worse at carrying oxygen. And what does that feel like? Not like bleeding. It feels like exhaustion sleep doesn't fix. Getting winded on a hill that never used to be a hill. Looking pale enough that other people notice before you do. Do you see the trap? Every one of those is something a person over 65 will hand to old age without a second thought. That's precisely what Gwen did, for a year. The practical insight here is the simplest one in this video, and it costs almost nothing. It's a routine blood test, a complete blood count. It's probably the most ordinary test in all of medicine. It's likely been done on you before, and it can pick up bleeding you cannot see. If you take one thing from today, if you've been tired in a way that rest doesn't touch, Don't watch it. Get a blood count. Everything so far has been make an appointment. This one is different. Black stool, and I mean genuinely black, like tar, sticky, with a smell that is unmistakably wrong, and unlike anything you'd call normal, has a name. Melena. And it is not a color. It's digested blood. When bleeding happens high up, the esophagus, the stomach, the first stretch of small intestine, the blood makes the entire journey through your gut alongside everything else. Enzymes and bacteria work on it the whole way. By the time it comes out, it doesn't look like blood anymore. It looks like tar. Two facts worth knowing, both from a standard clinical reference that's free to read online. It takes about 50 milliliters of blood in the stomach to turn stool black. That's a real bleed, not a trace. And roughly 90% of major gastrointestinal bleeding comes from that upper region. Common causes: a bleeding ulcer, severe gastritis, or swollen veins in the esophagus. The practical insight, and this one genuinely matters, because it prevents an unnecessary panic, and more importantly, prevents the opposite. Several ordinary things darken stool and are not melena. Iron supplements: Pepto-Bismol and anything with bismuth, black licorice, blueberries, activated charcoal. If you started iron pills last week and your stool went dark, that is very likely your iron pills. But, and I want to be careful here, iron makes stool a grayish, dark, ordinary textured black. Melena is tarry, sticky, and the smell is its own category. People who've encountered it don't need it described. If you're not certain which one you're looking at, that uncertainty is your answer. Black and tarry, even once, is a same-day call. Not tomorrow. Not let's see if it happens again. Same day. This one is about time, not appearance. The number here runs somewhere around 3.5% to 8.5% for a persistent change in bowel habit. Lower than bleeding or anemia, but well established, and it appears in every serious guideline. The key word is change. Not is your stool ideal. Not do you go every day. Bodies vary enormously and always have. What matters is that your normal shifted and then stayed shifted. Looser than it used to be, more often, or a constipation that's genuinely new for you. The comparison is against your own history, not against a chart. The one place there's a hard line worth memorizing: diarrhea lasting more than 4 weeks is no longer your gut reacting to something. 4 weeks is the standard clinical threshold for calling it chronic, and chronic diarrhea has a real differential. Inflammatory bowel disease, a parasite your immune system hasn't cleared, sometimes a growth irritating the lining. None of it improves by waiting longer. A day or two after a bad meal or a course of antibiotics is your body working. A month is your body telling you it can't fix this alone. Now the practical insight, and this is my favorite finding in all of today's research, because it's the opposite of what everyone assumes. In that pooled review, they looked at what happens when a second symptom shows up alongside rectal bleeding. Weight loss alongside bleeding pushed the risk up. A change in bowel habit alongside bleeding pushed it up. But abdominal pain alongside bleeding pushed the overall risk down. Pain, the scariest feeling symptom of the lot. Among people who were already bleeding, the ones who also hurt turned out to be at lower risk than the ones who bled without pain. Pain tends to point toward inflammation, toward something benign and angry rather than something silent and growing. I'm not telling you pain is good news, and I'm certainly not telling you to ignore it. I'm telling you this because it's the cleanest proof of the thesis of this entire video. How alarming a sign feels has almost nothing to do with how much it actually predicts. Your fear is not a diagnostic instrument. The quiet signs outrank the loud ones. That's the whole lesson. Here's the thing that struck me hardest while preparing this. I went through the competing videos on this topic, the popular ones, the ones with the big view counts. Not one of them mentions what I'm about to tell you. Not one. Every sign we've discussed asks you to notice something. But there is a test that finds the bleeding before there's anything to notice at all. It's called a FIT, a fecal immunochemical test. You do it at home. It looks for blood in your stool at levels no human eye could ever detect. What it does to the numbers is remarkable. Remember rectal bleeding at roughly 8 to 10%? In a study of patients whose doctors ordered a FIT, rectal bleeding plus a positive FIT took the number to 22.6%. But the far more important figure is the other direction. With a negative FIT, the negative predictive value was 98.9%. For change in bowel habit with a negative FIT, it was 100% in that sample. Do you understand what that buys you? It buys you the ability to stop worrying on evidence, not on hope. Everything else in this video helps you decide whether to be concerned. This test can actually answer it. And there's one more finding from that study I have to share, because it will change how you sit in that exam room. The researchers compared what patients reported against what doctors wrote down. Patients reported rectal bleeding 43.5% of the time. Doctors recorded it 25.6% of the time. Nearly half of it didn't make it onto the page. That is not a story about bad doctors. It's a story about 15-minute appointments and a subject nobody wants to raise. But it means something practical for you. If it isn't said clearly and said again, it may not get written down. And if it doesn't get written down, it doesn't get acted on. Say it plainly. Say it twice if you have to. That is not being difficult. That is being your own advocate. I need to be straight with you. Everything I've said so far assumes average risk. And for a number of you watching, that assumption is wrong. Here's the current guidance, and this is genuinely current. The American Cancer Society updated it in May of 2026, just weeks ago. For adults at average risk, screening starts at 45 and continues through 75 for anyone in good health with a life expectancy over 10 years. That's the headline. But here's the part that matters specifically for this audience, and I've never once seen another video on this topic mention it. Between 76 and 85, it becomes a genuine decision, not automatic. It depends on your preferences, your overall health, your life expectancy, and whether you've been screened before. It's a conversation, and it's your conversation. And over 85, the guidance is to stop. Screening is no longer recommended. I want to say clearly why that isn't a slight. A colonoscopy carries small but real risks, and the benefit of catching a slow-growing polyp only pays off over years. Past a certain point, the arithmetic genuinely changes. If you're 87 and someone told you not to screen, that wasn't giving up on you. That was good medicine. And in the other direction, if you have a family history of colorectal cancer, inflammatory bowel disease, or you've had polyps before, you may need to start earlier than 45, screen more often, or use specific tests. That's not the standard schedule, and you shouldn't try to fit yourself to it. The update also broadened the options. An updated stool DNA test, a new stool RNA test, and for the first time, a blood-based test. One honest caveat on that last one, because it's being marketed heavily. The ACS recommends the blood test only for people who decline or haven't completed a stool-based test. It's better than nothing, and it is not the best thing available to you. And whichever you choose, one rule holds. A positive result on any non-colonoscopy test needs a timely colonoscopy to follow. The at-home test isn't the finish line, it's the doorway. I promised you I wouldn't only bring you fear, so let me tell you about Marcus. Marcus is 68 from Tulsa. He came in about a year ago with the particular gray look of a man who hadn't slept properly in some time. He'd had narrow stool for close to 4 months, and he'd done exactly what Harold did, searched it, found the pencil stool claim, and concluded he had cancer. Then he did something I understand completely and see constantly. He didn't come in, for 4 months, because as long as nobody looked, it wasn't confirmed yet. Fear doesn't always make people run toward answers. Very often it makes them hide. His mistake wasn't stupidity. It was a small, human, completely ordinary one. He let a bad piece of information convince him the situation was hopeless, and then he protected himself from finding out. We examined him. He had an anal fissure, a small tear, some scarring, narrowing the very end of the canal. That was the entire explanation for 4 months of terror. We treated it, and because he was 68 and had never been screened, we did a colonoscopy while we were at it. They found one polyp, small, removed it during the same procedure, took about a minute. I want to be honest about what that means because I'm not going to oversell it. Nobody saved Marcus's life that day in a dramatic way. We don't know that the polyp would ever have become anything. Most don't. What we know is that a small risk was taken off the table permanently, and that he stopped being afraid. What stuck with me was what he said on the way out. He said, 4 months. I gave that thing 4 months of my life and it was never even there. That's the cost nobody counts, not the disease, the dread. Marcus paid 4 months for a myth. Let me get ahead of the questions I know are coming, because I'd rather answer them than have you searching for them at midnight. My stool floats, is that bad? Almost always no. Floating usually just means more gas, often from fiber fermenting, which is your gut bacteria doing their job. The exception worth noting, if it's greasy, oily, leaves a film, and smells notably foul, that's called steatorrhea, and it means fat isn't being absorbed. That one earns a visit. Buoyancy on its own does not. My stool is green, almost always fine. Either you ate something green, spinach, kale, broccoli, or things moved through fast enough that the bile didn't finish converting from green to brown. Remember the mechanism. Green is just bile that ran out of runway. If it keeps happening with no dietary explanation, mention it, because it may mean your transit is quick. It's not an emergency. I'm on a blood thinner. Does that change things? Yes, and this is important. Blood thinners and regular NSAIDs like ibuprofen make bleeding both more likely and more serious, and it's tempting to file any bleeding under, well, I'm on warfarin. Please don't. A blood thinner explains why a bleed is worse. It doesn't explain why there's something bleeding. Both questions still need answers. Do I need to do anything if I have no symptoms at all? Yes, and this is the part that flips everyone's intuition. Early colorectal cancer very often produces no symptoms whatsoever. That's exactly why screening exists as a separate thing from symptom watching. Feeling fine is not the same as being screened. It never was. Let me protect what you've just learned. Mistake 1. Watching the bowl instead of watching yourself. This is Gwen's, and it's the reason I made this video. It is completely possible to inspect your stool with total diligence every morning for a year and miss the actual signal, because the strongest sign on the list, anemia, produces nothing visible at all. If you take one habit from today, make it this. Pay as much attention to your energy, your color, and your weight as you do to the bowl. Those tell you more. Mistake 2. Assuming it's hemorrhoids. I understand why. Hemorrhoids are common, you've likely had them, and it's the comfortable answer. But polyps bleed, cancers bleed, and they bleed the same red. The trap is that having hemorrhoids doesn't protect you from anything else. You can have both, and many people do. If the bleeding is new or heavier or just different from your usual, it doesn't get filed under something you already know. Have someone actually look. Mistake 3. Letting fear stop you from finding out. This is Marcus's, and it's the most human one on the list. Somewhere out there is someone who's had bleeding for 3 months and hasn't called, not because they don't care, but because as long as nobody looks, it isn't real yet. I understand that impulse. But here's the thing worth holding on to. The overwhelming majority of people who get checked for these signs get good news. Around 9 out of 10 with rectal bleeding do not have cancer. The most likely outcome of making that appointment is relief. And in the small number of cases where it isn't, the earlier answer is always the better one. Mistake 4. Treating this video as a substitute for being seen. I've given you real numbers today and I've been careful with them. But none of it is a diagnosis. What I'm trying to do is help you know what's worth a phone call and what isn't, so you make the call sooner and worry less in between. That's all. The looking still has to be done by someone who can look. Let me make this simple, because a framework you'll actually use beats a perfect one you won't. Here's the whole video, folded into something ordinary. Stop the daily inspection. Genuinely. Studying your stool every morning for shape is not vigilance. It's anxiety wearing vigilance's clothes, and it watches the weakest signal we have. Let it go. Instead, notice 4 things over weeks, not days. Blood, and if so, mixed in or on the surface. Your energy, the kind of tired that rest doesn't fix. Your weight, moving without you trying. And whether your normal pattern changed and stayed changed. 2 things skip the waiting entirely. Black and tarry stool, even once, same-day call. And blood you can't explain, an appointment, not a wait and see. And separately from all of it, get screened on schedule, because the whole point of screening is that it works before there's anything to notice. The simplest possible version, 1 sentence. Stop watching the bowl, start watching your energy, and book the screening you're due for, today, whether or not anything feels wrong. 5 things. The first 2 are phone calls. 1. If you're between 45 and 75 and not up to date on colorectal screening, call this week. Ask which options they offer. If a colonoscopy feels like too big a first step, ask specifically about an annual FIT. At home, no prep, no sedation. The best test is the one you'll actually complete. 2. If you've been tired in a way sleep doesn't fix, ask for a complete blood count and say the words, "I want to rule out anemia." It's routine, it's quick, and it's the sign that hides. 3. If you're bringing up bleeding, bring the detail, how long, and whether it's mixed into the stool or on the surface. And say it clearly enough that it gets written down. Remember, nearly half of reported bleeding didn't make it into the record. Ask them to note it. 4. If you're between 76 and 85, don't assume either way. Ask directly. Given my health and my screening history, does continued screening still make sense for me? That is a real, legitimate conversation, and it deserves a real answer. 5. If you have a family history of colorectal cancer, inflammatory bowel disease, or prior polyps, none of the standard schedule applies cleanly to you. Ask what your schedule should be. Bring that question specifically. Let me finish Gwen's story because you've earned it. Gwen was anemic. We looked. There was a polyp, it was bleeding, and it came out during the colonoscopy. She never needed anything more than that. And here's the part I keep coming back to. Gwen had been paying attention for 8 months. She was not careless. She was one of the most diligent patients I've had. She just had bad information, and bad information pointed all that diligence at the one sign that couldn't help her. All that care, aimed at the wrong thing. That's what I hope today changed. Not that you'll worry more, that you'll worry about the right things, which, for most of you watching, will mean worrying considerably less. So here's my challenge, and it's a small one. In the next 7 days, do one of two things. Either book the screening you're overdue for, or, if you've been quietly frightened for weeks and haven't told a soul, tell one person. Then come back and tell me you did it. I read these. And if you know someone who's been checking the bowl every morning, waiting for a shape that was never the point, send them this. One more thing worth knowing. Colorectal cancer is now rising fastest in people younger than 65. If you have children in their 40s, they're in the screening window now, and most of them have no idea. Last thing, and I mean it seriously, everything today is educational, and it is not a diagnosis. If you take blood thinners or regular anti-inflammatories, if you have inflammatory bowel disease, a family history, or you're on iron, your situation has specifics that a video cannot account for, and they matter. Bring these questions to your doctor rather than settling them with me. Your body has been keeping an honest record this whole time. Today you learned which parts of it to actually read. I'll see you in the next one.